Left-to-right shunting forms the foundation for many acyanotic congenital heart lesions, so it is the right starting point when reviewing neonatal cardiovascular physiology. Flow across a defect always follows pressure gradients, moving from higher pressure chambers or vessels to lower pressure ones. In the newborn, systemic pressures normally exceed those on the right side, creating a natural direction of shunting from left to right. The magnitude of shunt flow depends on three factors. The first is the size of the opening. Small restrictive defects limit flow despite large pressure differences, while large non-restrictive defects allow significant volumes to pass. The second is the actual pressure difference across the communication. A high left-to-right gradient, as seen with a large ventricular septal defect, drives substantial shunting. The third is the relative resistance of the pulmonary and systemic circulations. At birth, pulmonary vascular resistance remains high, which limits shunting. As pulmonary resistance falls over days to weeks, left-to-right flow increases, often unmasking clinical symptoms of pulmonary overcirculation. These principles explain why a defect that appears well tolerated in the first days of life may later produce tachypnea, feeding difficulty, hepatomegaly, or signs of congestive heart failure. Recognizing the pressure and resistance-dependent nature of these shunts allows clinicians to anticipate changes in physiology over time and identify when intervention may be needed. Left-to-right shunting creates a sustained volume load on the receiving chambers. The atria and ventricles enlarge to handle the increased return, which raises myocardial oxygen demand and eventually compromises contractility. This chamber dilation is often the earliest structural change in significant shunt physiology. The pulmonary circuit receives both increased flow and pressure. Initially, this causes pulmonary overcirculation with interstitial edema and reduced compliance, which is especially problematic in preterm infants with immature lungs. Prolonged exposure drives vascular remodeling, including muscularization of small arteries and increased medial thickness. Rising pulmonary vascular resistance over time can produce irreversible pulmonary vascular disease if the shunt remains large and untreated. At the bedside, infants demonstrate the physiologic stress of this imbalance. Early findings include tachypnea, recurrent respiratory infections, and poor feeding related to high metabolic demand. As compensatory mechanisms fail, the burden on the myocardium progresses to congestive heart failure. Typical features are tachycardia, hepatomegaly, failure to thrive, and pulmonary edema on imaging. This sequence, from volume overload to pulmonary vascular change to eventual heart failure, illustrates the clinical trajectory of untreated large left-to-right shunts. In the early neonatal period, large left-to-right shunts may appear deceptively silent. During the first weeks after birth, pulmonary vascular resistance remains high, which restricts the amount of blood crossing from systemic to pulmonary circulation. Infants often remain asymptomatic through this period, even when defects are anatomically large. By 6 to 8 weeks of age, pulmonary vascular resistance has typically declined, and shunt flow increases substantially. This is the turning point when clinical manifestations emerge. The most consistent features are growth failure, feeding difficulty, and tachypnea. These findings reflect the combination of increased metabolic demand, pulmonary overcirculation, and reduced efficiency of systemic output. The timing of this transition is central to bedside recognition. An infant who appears stable in the first month of life, but then develops poor weight gain and respiratory distress at 6 to 8 weeks should raise immediate concern for an unrecognized large shunt lesion. The pathophysiology is not sudden. It reflects the predictable fall in pulmonary resistance that unmasks the hemodynamic burden. Recognizing this predictable timeline allows clinicians to anticipate presentation and arrange timely evaluation and management. Ventricular septal defect is the most frequently encountered congenital heart lesion. The defect represents an opening between the ventricles, allowing oxygenated blood from the left ventricle to cross into the right ventricle and pulmonary circuit. Several anatomic types exist, with perimembranous defects the most common. The hallmark physical finding is a harsh holosystolic murmur, best heard at the left lower sternal border. This sound reflects turbulent flow through the septal defect and often becomes more apparent once pulmonary vascular resistance falls. The physiologic consequence is left-to-right shunting. Small restrictive VSDs permit only minimal flow and may close spontaneously. Large, non-restrictive defects allow significant shunting, producing pulmonary overcirculation, left heart volume overload, and symptoms of congestive heart failure, such as tachypnea, hepatomegaly, and poor growth. Clinical urgency depends on defect size and its hemodynamic impact. Infants with small VSDS often remain well and require only monitoring, while those with large defects typically need medical therapy for heart failure and may ultimately require surgical closure. Ventricular septal defects are categorized by their anatomic location, each with characteristic clinical implications. Membranous, also called perimembranous, defects account for about 80% of cases. They lie in the membranous septum adjacent to the tricuspid and aortic valves. These lesions have a relatively higher spontaneous closure rate compared with other types, especially during early childhood. Muscular defects make up 15 to 20% of cases. They can occur anywhere within the muscular septum, often presenting as multiple openings that create a so-called Swiss cheese appearance. Muscular defects carry the highest likelihood of spontaneous closure, which often occurs in infancy. Inlet defects represent about 5% and are located posteriorly near the atrioventricular valves. These are strongly associated with atrioventricular canal malformations and therefore raise concern for chromosomal syndromes such as trisomy 21. Outlet, also termed supracrystal or canal, defects are less than 5% of cases. They are positioned just beneath the semilunar valves, particularly the aortic valve. The hemodynamic consequence of this location is progressive aortic cusp prolapse with risk of aortic insufficiency if left unrepaired. Small ventricular septal defects often reveal themselves by sound rather than by symptoms. Turbulent high-velocity flow through a narrow defect produces a loud, harsh murmur, typically grade 3 to 4 out of 6, best heard along the left lower sternal border. The paradox here is important to remember. Smaller defects create louder murmurs, while large defects may produce softer or less distinct sounds because the pressure gradient is lower. Despite the striking auscultatory finding, hemodynamics remain normal. Chamber sizes are preserved, pulmonary pressures are not elevated, and the infant demonstrates normal growth and development. Most small defects close on their own, with reported spontaneous closure rates approaching 70 to 80%, especially for muscular VSDS. Management focuses on careful observation rather than intervention. These infants generally do not require heart failure medications or surgery. Prophylaxis for infective endocarditis has historically been recommended, though current guidelines limit prophylaxis to select high-risk groups. Clinicians should confirm the most recent recommendations for their practice setting. The key teaching point is that small VSDs are loud but usually benign, requiring monitoring rather than aggressive therapy. Management of ventricular septal defects depends directly on the hemodynamic burden imposed by defect size. Small VSDs are typically benign, producing loud murmurs but no chamber enlargement or pulmonary hypertension. These are best managed with observation, allowing time for spontaneous closure, which is common. Moderate VSDs often create enough shunting to produce congestive heart failure symptoms once pulmonary vascular resistance falls. Medical therapy with diuretics, afterload reduction, and nutritional support stabilizes most infants. Surgical intervention is considered if growth failure persists or medical therapy cannot control symptoms. Large VSDs present a higher level of urgency. They cause early congestive heart failure, and if left uncorrected, progressive pulmonary vascular disease. Medical therapy addresses symptoms in the short term, but definitive closure is recommended within the first year of life to prevent irreversible pulmonary hypertension. The unifying principle across all sizes is prevention of permanent pulmonary vascular damage. Timely recognition of hemodynamic significance ensures that intervention occurs before vascular remodeling renders the defect inoperable. An atrial septal defect allows blood to flow from the higher pressure left atrium into the right atrium, producing a left-to-right shunt. Boom, my tot! The added preload increases right ventricular output, resulting in right ventricular volume overload and dilation over time. Despite this extra volume, atrial shunts rarely lead to congestive heart failure in infancy. Pulmonary pressures remain normal because the shunt occurs at the atrial level where gradients are low. For this reason, most neonates with isolated ASDS are asymptomatic in the early period. The classic auscultatory feature emerges later in childhood, fixed splitting of the second heart sound. This occurs because the augmented right-sided flow prolongs right ventricular systole, keeping pulmonic valve closure consistently delayed regardless of respiration. Atrial septal defects are classified by their anatomic location and embryologic origin. Secundum ASDs represent over 2/3 of cases, making them the most common type. They occur in the region of the fossa ovalis and often arise from incomplete closure or stretching of the foramen ovale. These lesions are frequently suitable for percutaneous device closure when size and rim anatomy are appropriate. Primum A SDS account for about 20%. They are part of the atrioventricular septal defect spectrum and commonly associated with a cleft mitral valve. Because of this association, primum A SDS nearly always require surgical repair rather than device closure. Sinus venosus ASDS make up roughly 10%. They occur near the entry of the superior or inferior vena cava and are frequently associated with partial anomalous pulmonary venous return, where one or more pulmonary veins connect abnormally to the right atrium or vena cava. This anatomical relationship explains why surgical repair is necessary to redirect pulmonary venous flow appropriately. Each type carries distinct clinical implications, and recognizing the subtype guides both prognosis and management strategy. In the neonatal period, most atrial septal defects remain clinically silent. Infants are usually asymptomatic, and findings are often incidental during routine evaluation. On auscultation, a soft systolic ejection murmur may be heard at the left upper sternal border, generated by increased flow across the pulmonic valve, rather than turbulence through the defect itself. Electrocardiography may reveal right ventricular hypertrophy, a reflection of chronic right-sided volume loading rather than pressure overload. These features distinguish ASDS from ventricular-level shunts, which more readily produce congestive heart failure in early infancy. Closure is indicated when there is evidence of significant shunting, defined as a pulmonary to systemic flow ratio greater than 1.5 to 1, accompanied by right ventricular enlargement on imaging. Because spontaneous closure is unlikely for true ASDs beyond early childhood, intervention is usually planned after 3 to 4 years of age. This timing allows for continued growth while preventing long-term complications such as arrhythmia, right heart dilation, and pulmonary vascular changes. Atrioventricular canal defects, also called atrioventricular septal defects, arise from abnormal development of the endocardial cushions. They are strongly associated with trisomy 21 and occur along a spectrum of severity. In the complete form, the atrial and ventricular septa are deficient, creating a large primum atrial septal defect and an inlet ventricular septal defect. Instead of 2 atrioventricular valves, there is a single common valve that bridges both ventricles. This anatomy permits extensive left-to-right shunting at multiple levels and often leads to early congestive heart failure. The partial or incomplete form preserves separate mitral and tricuspid valves. The defining features are a primum atrial septal defect combined with a cleft in the anterior mitral leaflet, which can cause mitral regurgitation. Ventricular septation is usually intact. A transitional atrioventricular canal lies between the two extremes. It usually consists of a primum atrial septal defect, a cleft mitral valve, and a small inlet ventricular septal defect. Hemodynamics in these cases often resemble a simple atrial shunt, though the presence of mitral regurgitation or residual ventricular level shunting can increase complexity. Atrioventricular canal defects show one of the strongest genetic associations in congenital heart disease. Roughly 40 to 50% of infants with Down syndrome have some form of AV canal defect, making trisomy 21 the single most important clinical correlation. These defects are also linked to heterotaxy syndromes, where abnormal left-right patterning produces complex intracardiac and extracardiac malformations. In addition, they can occur with other genetic syndromes and chromosomal anomalies, reflecting the central role of endocardial cushion development in cardiac morphogenesis. For clinicians, the critical bedside point is that the discovery of an AV canal defect in a neonate should immediately prompt evaluation for trisomy 21 and consideration of broader genetic testing. Recognizing these associations guides anticipatory counseling, directs genetic workup, and prepares the care team for potential extracardiac complications. Atrioventricular canal defects create abnormal communications at both atrial and ventricular levels. Blood is shunted from the higher pressure left atrium and ventricle into the right-sided chambers, producing substantial left-to-right flow. This dual-level shunting markedly increases pulmonary blood flow and places a volume load on the right ventricle. Another major component is atrioventricular valve regurgitation. The common valve is often incompetent, and the mitral leaflet is most affected. Regurgitant flow compounds the volume load on the left atrium and ventricle, further driving pulmonary venous congestion. Complete forms typically present early, with congestive heart failure becoming evident around 2 to 3 months of age, corresponding to the fall in pulmonary vascular resistance. Infants at this stage demonstrate tachypnea, poor feeding, hepatomegaly, and failure to thrive. Because of the large, unrestricted shunts and additional valve regurgitation, pulmonary arteries are exposed to both increased flow and pressure. This accelerates vascular remodeling, placing infants with complete AV canal at high risk for early development of pulmonary vascular disease, if not repaired. Infants with atrioventricular canal defects typically present early with signs of congestive heart failure. Feeding difficulties, tachypnea, and poor growth reflect the combined burden of large left-to-right shunts and atrioventricular valve regurgitation. On auscultation, two characteristic murmurs are often appreciated. A harsh, hollow systolic murmur corresponds to flow across the ventricular septal defect component, while a mid-diastolic rumble at the apex reflects increased flow across the mitral portion of the common valve. If the atrial shunt is large, fixed splitting of the second heart sound may also be present. Physical examination frequently reveals hepatomegaly and a hyperdynamic precordium. Imaging typically shows cardiomegaly, driven by both chamber dilation and volume overload. These findings together establish the classic profile of AV canal presentation in early infancy. Initial therapy for atrioventricular canal defects targets the symptoms of congestive heart failure. Diuretics reduce pulmonary congestion, afterload reduction with agents such as ACE inhibitors improves forward flow, and digoxin may be used to augment contractility. Because these infants often have poor growth, nutritional support and caloric supplementation are essential parts of care. Definitive treatment requires surgical repair. For complete AV canal defects, repair is usually undertaken between 4 and 6 months of age before pulmonary vascular disease can develop. In partial forms, surgery may be timed later, but still within the first year if symptoms persist. Earlier repair is indicated if medical therapy fails to control heart failure or if pulmonary hypertension is advancing. The guiding principle is prevention of irreversible pulmonary vascular disease. Delaying surgery beyond the first year risks loss of operability due to rising pulmonary vascular resistance, which permanently alters outcomes. With timely repair, long-term prognosis is excellent, though valve regurgitation remains a potential residual issue. Definitive repair of atrioventricular canal defects requires closure of the septal defects and reconstruction of the atrioventricular valve. The standard operation is the two-patch technique, in which one patch closes the primum atrial septal defect and a second patch closes the inlet ventricular septal defect. This restores normal septation between the atria and ventricles. Equally important is repair of the atrioventricular valve. The cleft in the mitral leaflet is surgically approximated to restore competence and reduce regurgitation. Valve reconstruction is critical to long-term outcome since residual insufficiency can drive recurrent symptoms or reoperation. Preoperative assessment focuses on ensuring that both ventricles are adequately sized and that atrioventricular valve tissue is suitable for repair. Balanced ventricular volumes and preserved ventricular function are essential for a successful biventricular repair. In infants with Down syndrome, a special consideration is the variability in pulmonary vascular resistance decline. Some children demonstrate a slower fall in resistance, which can delay the onset of symptoms, while others progress rapidly to pulmonary vascular disease. This variability reinforces the importance of careful hemodynamic assessment and individualized surgical timing. Congestive heart failure in infants describes the inability of the myocardium to pump enough blood to meet metabolic demands. In acyanotic lesions, the driving mechanism is usually volume overload from large left-to-right shunts or severe atrioventricular valve regurgitation. The most common neonatal culprits are large ventricular septal defects, complete atrioventricular canal defects, and significant mitral or tricuspid insufficiency. These lesions channel excessive blood into the pulmonary circuit, raise venous return to the left heart, and produce pulmonary congestion. Clinically, the syndrome is recognized by a consistent group of findings. Tachycardia reflects compensatory attempts to maintain output, while tachypnea signals pulmonary overcirculation and reduced compliance. Hepatomegaly results from systemic venous congestion. Feeding difficulties and rapid fatigue are common because the infant cannot sustain the increased energy demands of feeding while struggling to maintain circulation. The cumulative effect is impaired growth. Poor weight gain and failure to thrive are hallmark consequences when congestive heart failure is prolonged. Recognizing this pattern early allows timely intervention, both medical and surgical, to stabilize hemodynamics and protect long-term developmental outcomes. Medical therapy for neonatal congestive heart failure aims to reduce symptoms, improve efficiency of cardiac output, and support growth until definitive repair can be performed. Loop diuretics such as furosemide are first-line agents, relieving pulmonary congestion and systemic venous overload. Afterload reduction with angiotensin-converting enzyme inhibitors such as captopril or enalapril lowers systemic resistance, allowing the left ventricle to eject more effectively. Digoxin can provide modest inotropic support, though its use has declined compared with historical practice, and is reserved for cases where improved contractility is needed. Nutritional therapy is equally important. Infants with heart failure have markedly increased energy demands, while feeding intolerance limits intake. High-calorie formula, breast milk fortification, and direct caloric supplementation are often necessary to sustain growth. The overarching goal is to stabilize circulation and promote adequate growth while awaiting surgical or catheter-based correction of the underlying lesion. Success is measured not only in symptom relief, but also in the infant's ability to maintain weight gain and developmental progress despite the hemodynamic burden. Eisenmenger syndrome represents the endpoint of uncorrected large left-to-right shunts. Continuous exposure of the pulmonary vasculature to high flow and pressure leads to progressive remodeling of small pulmonary arteries. Medial hypertrophy, intimal proliferation, and loss of vascular compliance eventually create irreversible pulmonary vascular disease. This process is accelerated when the pulmonary to systemic flow ratio exceeds 2:1. The risk increases substantially after 2 to 4 years of age if the defect remains unrepaired. Once pulmonary vascular resistance approaches or exceeds systemic resistance, the shunt reverses direction. Right-to-left flow develops, producing cyanosis, digital clubbing, and polycythemia. At this stage, the lesion is no longer operable. Repair of the underlying defect cannot reverse pulmonary vascular changes, and patients face significant morbidity and reduced survival. The clinical importance lies in prevention. Timely surgical or catheter-based closure of significant shunts during infancy or early childhood protects the pulmonary vascular bed and eliminates the risk of Eisenmenger physiology.